Assalamu alaikum. I am Dr. Mohamed lecturer of forensic medicine and clinical toxicology. Today we will study nasogastric intubation. What are indication of gastric lavage or nasogastric intubation? The indication is large toxic ingestion within 1 hour. So this is my patient presented at emergency department and you want to wash his stomach. First, introduce yourself to the patient. After that, explain the procedure or the technique to the patient. Now take brief history from the patient about previous nasal surgery, previous nasal trauma. Then with your torch, examine the nose on both sides for polyp, for obstruction, any septum deviation. Then you can perform a very simple test which is called inhale separately. Close one side or one nostril and ask the patient to inhale from the other nostril. Then the opposite side, the patient tells you which side is more patent. So I decided to introduce the nasogastric tube through the right side or the right nostril. Before I introduce the tube, I have nasal decongestant tube. I will put 2 or 3 drops of nasal decongestant drops to the right nostril. Why? To achieve decongestion, which means lower risk of epistaxis and more patent airway or more patent side. After the decongestant, you can see it's called lidocaine gel. Lidocaine gel is local anesthesia. I will put lidocaine gel to the nose of the patient and ask the patient to sniff and swallow to achieve anesthesia, because this technique is annoying to the patient. So after you put decongestant, you can put now lidocaine gel. Ask the patient to sniff and swallow like this, sniff and swallow to achieve anesthesia to the nasopharynx, oropharynx, and even the esophagus. So I prepared my nose. Now I will choose the tube. You can notice we have different colors of the tube. These are different colors of the tube. Each color has its own size. I arranged them from the greatest diameter to the least diameter. The red is the greatest diameter, followed by the orange, then the green, then the white, and finally the black. If your patient is child, you will choose either the black or white tube. If your patient is adult male, you will start with the red tube, and if you fail to introduce it, you will shift to the orange. But if your patient is female, you will start with the orange, and if you fail to introduce the orange, you will shift to the green. So I will choose, for example, the green tube, and I will intubate the patient. First, I will measure the length I need inside the patient. Tip of the tube on tip of the nose, then to the air lobule, then down to the xiphoid process, and I will take a mark. You can see it is already marked here. So this is my mark. So again, which length I need? Tip of the tube on tip of the nose to the air lobule, then downward to the xiphoid. This length I want to, and I will mark or label this length. So this length will be inside the patient, and this length will be outside. I measure my length. Now I will coil my tube 1/3. Why coiling my tube? To take the anatomical shape of the nasopharynx. Coil your tube on your hand, lower 5 inches to take the anatomical shape of the nasopharynx. Then lubricate the tube. Lubricant. I lubricated my tube with lubricant. Now I will introduce my tube like this. Push the tube backward and laterally. And if you find resistance at the level of oropharynx, you can rotate the tube upside down and continue insertion of the tube. While you are inserting the tube, it's better to ask the patient to swallow something, water or something, simple water with you to facilitate the passage of the tube. So I will introduce my tube till my mark. what now? I introduce my tube till the mark. Okay, this is my mark. I introduced my tube till the mark. Before fixation of the tube, I wanted to make sure that the tube is inside the stomach, not inside the trachea, because there are two pathways. The tube may pass to the trachea or to the esophagus. I wanted to make sure the tube is in the esophagus and in the stomach. Ask the patient to talk. If the patient talking to you, patient is calm, no cough, no cyanosis, this is a good sign. So talking patient with you or to you is a good sign, and it is a confirmatory sign that the tube is inside the esophagus, not inside the trachea. Second, aspirate gastric content with a 50 milliliter syringe. Try to aspirate gastric content. Okay, so you can see this is gastric content aspirated from the stomach. This aspirated gastric content, and I can there is no litmus paper, I can test it on litmus paper. It is expected to be acidic because it is from the stomach, so it will make the blue litmus paper turn red. After that, I will perform a very simple test, which is called the traditional confirmatory method or the stethoscope method. I will bring 10 to 15 milliliter air from the atmosphere like this. And before I push them through the tube, I will wear my stethoscope and put the stethoscope over the epigastric area, and now I will push the air. It's expected to hear bubbling sound or hissing sound, the effect of the air on the fluid content of the stomach. Another confirmatory method is to perform chest X-ray, which is the most confirmatory method and the best confirmatory method. You can also examine the tube, which should be straight forward here, not coiled inside the mouth. With your torch, examine the tube. It is straight here behind the uvula and not coiled inside the stomach. So again, what are the 5 confirmatory methods for the nasogastric intubation to make sure that the tube is inside the stomach? The patient talked to you, you aspirated fluid content and tested it over litmus paper. You examined the tube, should be straight here behind the uvula, not coiled. You performed the stethoscope or traditional method, which air from the atmosphere outside and push your air while you are hearing on the epigastric area. And the last method is to perform chest X-ray. After that, you made sure, you are sure that the tube is inside the stomach. Now you can fix the tube. You can see this Y-shaped adhesive tape. Okay, Y-shaped adhesive tape. Now I will fix the tube. The broad side of the tape will be over the nose, and we have 2 arms of the Y-shaped adhesive tape. It will be coiled like this over the tube. Now the tube is fixed, and now I will proceed to wash my stomach. The patient is on left lateral position. I will aspirate the gastric contents and discard it. Then I will introduce saline or tap water and remove it again. You can introduce 100 to 300 milliliter per wash and remove them, and continue till you have a clear content, till you have a clear fluid. You insert the water and you are getting back water. After you finish and you get a clear fluid, the patient is upside again. Then you can now remove the tape. Ask the patient to hold his breath for a while and remove the tube. Now we have finished the nasogastric intubation and the gastric lavage. You can notice we started the procedure or the technique while the patient was standing position. So the ideal position for conscious patient is standing position. What if your patient is comatose? If your patient is comatose and you need to intubate him, insert nasogastric tube, the patient is comatose, so it will be in supine position. you can perform mild neck flexion like this, okay, and now you can insert the tube. So comatose the patient, supine position with mild neck flexion. Neck flexion means the neck to the front, okay, and it is better to insert into tracheal tube to avoid aspiration. Okay, there is problem that may face you, which is gag. The patient is vomiting. I will overcome the gag reflex or excessive gagging with what's called lidocaine spray. Lidocaine spray. If your patient is gagging, you can put spray on the posterior 1/3 of the tongue. Why? To make anesthesia and to stop the vomiting. Thank you very much.
هاخد منه